today I want to bring to your attention a topic that it's not frequently found in the sleep medical literature. And I'm going to talk about recurrent isolated sleep paralysis and what do we know so far. I have no disclosures in regards with this topic. Why did we choose this topic? It all started with a case that me and Dr. Stroll encountered in our clinic. That was a little bit earlier this year, and it was a 30-year-old male that came with a chief complaint of sleep paralysis. He was reporting episodes 3 to 4 times a week, usually upon awakening. They were lasting 30 seconds to 1.5 minutes, but it seemed to be that they were lasting much longer, up to 5 minutes. He first started to experience that 5 years prior to this presentation, when he was in heroin rehab and he was placed on Suboxone. And the episodes then stopped once he was switched to Subutex, but then subsequently went back and he started to have these episodes again. And he was perceiving these episodes as a nightmare, and they were triggered by his by long recovery sleep periods. And of note, his sleep-wake schedule was not quite the best, and that was mostly because of his job. He was working in road construction, and he had a very irregular sleep-wake schedule, working from 3 a.m. to 9 a.m., sometimes from midnight to 5 a.m. He was not using alcohol. He's been otherwise sober, except for vaping, and he was taking trazodone for what he calls sleep. He didn't exhibit any sleep disorder breathing symptoms, no parasomnias, no cataplexy, no neurologic dysfunction, but he did have fatigue and moderate daytime sleepiness with an Epworth of 14, but no history of car accidents or near misses. And he also had a history of hepatitis C. At some point, chronic hepatitis C, at some point his liver enzymes were elevated, but they've been normal since last year. Outside of the past medical history that I already mentioned, he also carried a history of insomnia, generalized anxiety disorder, erectile dysfunction, and a moderate depression episode. And there was no family history significant for any sleep disorders or neurological disorders. Pretty much his family history was cardiovascular disorders, and social history I already mentioned. So current medications, as I mentioned, just trazodone and Suboxone. And he also had a remote history of 2 episodes of head trauma. One of them he was hospitalized for, and the other one not. One was 10 years ago, the other one 5 years ago, and his most recent LFTs were normal. Also, there was no personal family history of hypokalemia or hypokalemic paralysis. And my presentation will bring on all the important points. Why do I mention this? So moving forward, after we saw this patient, we went on a journey of kind of looking into the current literature and see what's out there that we could connect these episodes to his symptoms and possible triggers. So my objectives for today started with this review of current literature, and we looked into pathogenesis and pathophysiology of recurrent isolated sleep paralysis. We will review the clinical features and its cultural significance, potential differential diagnosis, predisposing, precipitating factors, review of the current therapeutic approach and impact on quality of life, future potential therapies, and what research is happening out there. First, let's see what is sleep paralysis. So first of all, there's 2 categories that we need to clearly differentiate. There's an isolated form, isolated sleep paralysis, or there's the form that we found in the context of narcolepsy. Now, the recurrent isolated sleep paralysis is the recurrent form of isolated sleep paralysis and is listed in ICSD-3 as a REM sleep-related parasomnia that mostly occurs when a REM-based atonia perseverates into wakefulness. And most individuals will describe dream activity and the conscious paralysis with vivid, multi-sensorial, and most of the time negative feelings or negative impact. And it's most of the time an unpleasant experience. That's how the patient would describe it. And the patient would have a hard time understanding that, which would lead to fear, distress, and even insomnia. And the criteria is listed in the ICSD-3, and all of these 4 criteria need to be met, are the following. Sleep paralysis, so isolated, recurrent, inability to move the trunk and all of the limbs at sleep onset or upon awakening from sleep. Each episode lasts seconds to a few minutes. The episodes cause clinically significant distress, including bedtime anxiety or fear to sleep. And this disturbance is not better explained by another sleep disorder, especially narcolepsy, or a mental disorder or other medical condition, medication, or substance use. Now, the literature describes essential associated features, and these refer to when the sleep paralysis happen. It could happen at sleep onset, which we call hypnagogic or predormital form, or on awakening, hypnopompic or postdormital form. And the patient is unable to perform voluntary movements for the limbs, trunk, head, and also he is incapable to speak, while his ventilation is usually unaffected. And the fact that this happened with in association with intentional sleep would be like the first way in which we differentiate this from cataplexy, which is usually associated with wakefulness, right? What's important is that the conscience is preserved, and the patient, if allowed to sleep and not awakened by sensory stimulation or by spontaneously stopping of the episode, then he would just re-enter sleep and would awaken later. The 2 most frequently described in the literature associated features with isolated sleep paralysis and outside sleep paralysis in general are the hallucinatory experience and anxiety. So a patient could experience different types of hallucinations, auditory, visual, tactile, or they would feel like a presence in the room. And they were describing 20 up to 25 to 75% of the patients. And because these episodes are perceived as dramatic and they could be emotionally profound, they lead to secondary anxiety. And they actually can leave a lasting memory that the patient can vividly recall even years after the episodes. So after reviewing the literature, this is kind of what I found in terms of what the patients describe. So first of all, this inability to move. They can't move, not even their fingers, and they can't sleep. But they are completely aware of their surroundings, or they feel partially asleep. They have anxiety and all sorts of somatic sensations, including chest pressure or a feeling of suffocation. And they can resume what they call normal breathing once the event is done. They can try to scream, but are only able to produce a whisper maybe. And they have a strong feeling of impending doom, of being chased, of having to escape some imminent danger, or they can feel that someone else is in the bedroom, what is called a felt presence, which has been described as either the intruder or the incumbus phenomenon, which is the intruder that physically is oppressing the sleeper. I found some sleep questionnaires that can be used to facilitate the diagnosis of recurrent isolated sleep paralysis, but keep in mind that none of these are validated. They are described in few papers, but I just want to highlight on one of them. The most thorough interview is the fearful isolated sleep paralysis interview. And then there's others like the Duke structured interview for sleep disorders, unusual sleep experiences questionnaire, the Waterloo unusual sleep experience questionnaire, muting parasomnia screening. Again, different authors have tried this on, I would say, not large patient samples. And just for exemplification, the recurrent fearful isolated sleep paralysis questionnaire has 3 main points. The frequency in the past 6 months of the paralysis events, the overall fear or distress during the event, and the interference with the daily living in the past 6 months. But again, none of these validated. I just wanted to highlight that they exist out there. And now that we talked about the diagnostic criteria and the associated features, there is, I would say, pretty large literature in terms of cultural significance of sleep paralysis and how it's perceived in the whole world. And I can easily say there is a description of this phenomenon on pretty much every continent. But for the sake of the time, I'm just gonna delineate some of them. First of all, because it's described in so many cultural contexts, that will make a true epidemiologic study difficult. The sleep paralysis phenomenon have been thought to have a role in many supernatural beliefs, including nocturnal alien abductions or demonic attacks. And it's been described since the ancient Egypt, and you can see depicted here the jinn attack, which is a spirit-like creature that can kill its victims. And actually in ancient Egypt, it's been associated with an impending death feeling in like 50% of the patients. Moving down in folklore, this phenomenon is known as the night hag or the old hag. And this is a creature that immobilizes the person as if standing on the chest, as depicted in the picture over there.
It looks like he's sitting.
Sorry, sitting on the chest. And it's been described in many countries, but just a few examples. In Cambodia is thought to be the ghost that pushes you down. There's a strong cultural and association in Italy, and it has a different name based on the area from Italy that the patient comes for. Most frequently it's known as the panda feci attack, and it's known as the trot, for example, in the northern Italy. And there are also different ways by which one could get rid of these feelings or creature, for example, like making the sign of cross. Moving forward in Newfoundland, same sleep paralysis is referred as an old hag, and its victims would be completely conscious but unable to speak or move, and they report that a person or an animal would be on top of their chest. And despite the name, the creature is described either as male or female, and again, ways to get rid of it, like sleeping with the Bible under the pillow, or calling the sleeper's name backwards, or sleeping with a board on top of chest, which is called a headboard. And it's also most recently it's been a pop culture figure and appeared in films and plays and in crafted objects. Other examples: Canadian Eskimos, Japanese tradition, it's named Kanashibari. Nigerian culture is described. Modern manifestation, the alien abductions that already mentioned. In Brazil, it's called pisaderia, and it's in Brazilian folklore. It's a crone with long fingernails who lurks on roofs at night and comes on the chest of those who sleep on a full stomach with the belly up. So different cultural balances of this phenomenon. I thought those were interesting. Again, there's much more description out there, but I just wanted to exemplify some of them. What do we know about the epidemiology of this disorder? There's quite not so many studies out there, and they're usually done on small population samples. But the isolated sleep paralysis, so one episode of sleep paralysis, is thought to happen or to be experienced at least once by up to 40, maybe 50% of the general population. So it's a pretty frequent finding, but the recurrence is not as frequent. The reporting prevalence varies anywhere between 4.7 and 41% based on the study. And the incidence on the most recent papers, it's thought to be around 7.6% of the population. There are some studies showing an increased prevalence in African American population. The mean age of onset is actually in the teenager years, around 14, 17 years of age, and even younger than that. But it usually would present and would be reported by the patient in the second or third decade. And it affects equally both sexes. There are no known complications, so there is a benign disorder. And there is a familial form that's been described. It is thought to have a maternal form of transmission, but again, not enough genetic studies out there about it. And what I thought was very important, even though it's already proven that this disorder starts in childhood, there's pretty much nothing or very little literature about the childhood form of recurrent isolated sleep paralysis. So this is a potential future investigation for this disorder. So while I was doing my literature research, I found this paper, which is actually 22 years old, but I feel it was probably the most comprehensive. It's done by two authors that have written more papers about the isolated sleep paralysis, and they are from Italy. And they had a larger sample of patients that they followed from 1996 to 1998. It was 264 patients, and they collected messages from these patients in regards with their experience of sleep paralysis. And they also described some clinical similarities between the recurrent form of isolated sleep paralysis and channelopathies, in particular the periodic paralysis. And they also postulated or an activation of limbic system structure, suggesting that is suggested to explain some of the most common subjective experiences associated with sleep paralysis. So from their paper, in terms of age of onset, their patients, 1/3 of them recorded that it started when they were younger than 12 years of age, and 1/3 between 13 and 19 years of age. So speaking of that early onset in childhood or teenage years, and only the rest of the patients reported that the disorder started later. In terms of frequency of the episodes from the same paper, most of the patients reported that it's recurring, which is somewhat different than other papers. So like 36%, 1/3 of the patients reported recurring episodes, but most of them had more like isolated episodes. And some of them, a small percentage, 6.8%, reported that the episodes are progressively decreasing as they are moving towards adulthood. In terms of time of onset, the big majority, more than 50% of the patients, described that their sleep paralysis happens on awakening. 1/3 reported that it happens at sleep onset, and 40% reported that it could be either sleep onset or on awakening. And what are some subjective phenomena associated with the sleep paralysis? 2/3 of the patient reported that fear, terror, or panic, and 1/3 of them reported they felt a presence or phantom noises, some auditory hallucinations. Some of them reported out-of-body experiences, a feeling of floating, maybe even a physical touch, smaller percent, 7.6%. But the big majority perceive this phenomenon as an unpleasant experience, mostly with this fear, terror, and panic. And the authors in the same paper describe the hallucinations as paroxysmal hallucinations, and a person could exhibit either motor, other sensorial hallucinations, visual, acoustic, or vestibular hallucinations. So different types of hallucinations described in different percentage by their population sample. And now that I mentioned that 2/3 of the patient experience unpleasant sensations, here's a group of researchers from Czech Republic that try to see if sleep paralysis could be pleasant. And they had, I would say, a decent number of patients that they talked to, of 172. And they found that the pleasant sleep paralysis is actually a fairly common experience in 23% of the patient population. And these pleasant episodes involve some admixture of fear. They were more likely to involve the vestibular motor sensations like illusory body movements. And some patients even reported the ability to induce these hallucinations. But contrary to what one would expect, neither a lower trauma symptomatology nor higher levels of reported life satisfaction predicted pleasant sleep paralysis. But they found that this patient had a higher ability to lucid dream, higher levels of being open to new experiences, and that kind of made their episodes appear more pleasant. And now that we described the possible diagnostic criteria, the cultural significance of this disorder, and different types of associated symptoms, I want to take a few minutes and talk about predisposing and precipitating factors. And I know this slide looks busy, but I try to put everything that I found on the same page. And it's pretty hard to find data on this. There's scattered papers and not so big patient samples. So what seems to be mostly associated with sleep paralysis in terms of predisposing factor is the sleep deprivation and an irregular sleep-wake schedule, including any sort of schedule disruption, jet lag, or shift working. Also, I would say, pretty well described in literature is the association with psychiatric conditions, such as bipolar disorder, panic disorder. Studies report a prevalence of 20.8%, PTSD, 22.2%, and generalized anxiety disorder, 15.8%. Also, there's an association with the use of anxiolytic medications, especially benzodiazepines and SSRIs, which is somewhat interesting, as some authors actually recommend SSRIs for the treatment of this disorder, as we will see later in my presentation. But again, more data to be discovered there. Other possible medications: barbiturates, hydroxyzine, pregabalin, alcohol, opioid use, any kind of mental stress. There's some possible association with supine position, but there's mixed data regarding the association with sleep disorder, breathing, or sleep apnea. There is a described association with the sleep-related leg cramps, and also with traumatic brain injury, with varying prevalence in studies from 5% to 15%. And also there's a description of possible association with hypertension and Wilson disease. And from the paper of the Italian authors that I mentioned earlier in my presentation, some precipitating factors that they found in their patient sample it seemed to be the isolated sleep paralysis and recurrent sleep paralysis seemed to be associated with a nap at 80.3% of their patients, and with the sleep schedule alteration in about 8% of the patient. Pretty much the others that I mentioned, they also mentioned caffeine. I didn't really find anything else in the literature about that. But the most important one seems to be the sleep schedule alteration. Moving forward, I just want to bring up to your attention this paper is from a European study 2017-2018. And these authors used the global score of the Pittsburgh Sleep Quality Index, and they actually had 860 individuals that were young, 22 to 32 years of age, and 66% of them were females. And they again found that the most frequent predictors of sleep paralysis were sleep latency, daytime dysfunction, and these patients also had associated symptoms of insomnia, sleep problems related to traumatic experience, pre-sleep arousal, cognitions about sleep, excessive daytime sleepiness, but they found no relationship with sleep disordered breathing or diurnal preference of sleeping arrangements. Again, the reason why I brought this paper in is because I felt their sample was probably the highest from these other papers, and having 860 individuals. Some studies out there talk about some personality traits that are associated or could be triggers for recurrent isolated sleep paralysis. It is described that higher levels of dissociation, having like more imagination, more beliefs in paranormal, supernatural, could lead to maybe experience this phenomenon. As with the PTSD, it's unclear what is the causal link with these personality traits. And the question remains, are those with paranormal beliefs more likely to have sleep paralysis, or those with sleep paralysis more likely to have subsequent paranormal beliefs? So something maybe for the future researchers to look into. And now that we've talked about the diagnosis and all the experiences the patient have, let's move a little bit into the differential diagnosis. And again, I'm going to bring a few papers on that because different data is scattered. But from the Italian paper, say the most important differential diagnosis that needs to be done is with cataplexy and narcolepsy that usually happens in a waking state. Atonic seizures, which usually also happen in waking state, drop attacks that are related to sleep-wake transition, hypokalemic paralysis, and documentation of a low seropotassium during these attacks, hysterical or psychotic states with immobility, drug withdrawal or abuse, and REM rebound, which is interesting because it could also be a cause for sleep paralysis. And there's some literature regarding sleep paralysis and channelopathies, and especially related to hypokalemic, but also hyperkalemic periodic paralysis and other types of periodic paralysis or channelopathies. All of these would have episodic occurrence and genetic factors attributed to, but the precipitating factors differ. And for example, for the hypokalemic periodic paralysis, which is more frequently brought up in the differential, high carbohydrate meals, alcohol, and like even sleep could be a precipitating factor. So more confounding data here. other paper that I found who was discussing about the differential diagnosis is bringing up other sleep disorders such as REM and other REM and non-REM parasomnias, like exploding head syndrome, nightmare disorder, sleep terrors, and also brings in the differential diagnosis of psychiatric disorders such as nocturnal panic attacks and PTSD, and schizophrenia and other psychotic disorders. As I was doing my research for this presentation, probably this was the most challenging part, trying to figure out about pathology, pathophysiology of sleep paralysis, because there's not a lot of research out there. We know that it's a REM sleep parasomnia, and it's a state dissociation thought to represent episodic intrusion of the REM sleep into wakefulness. Early onset REM sleep after forced awakening has been shown to predispose a person to having sleep paralysis. It may relate to brainstem norepinephrine neurons in the locus ceruleus being quiescent during REM sleep and failing to revert to spontaneous pacemaker-like firing activity on waking, which is thought to lead to cortical arousal. The paralysis is consistent with atonia, as we see in the normal REM periods, produced by hyperpolarization of the spinal motor neurons originating in cholineceptive neurons in dorsolateral regions of the pontine reticular formation. And it was postulated that an activation of the limbic system structures is necessary in order to explain some of the most common subjective experiences associated with sleep paralysis, and especially the hallucinations. Not sure what happened here. Sorry about that. So I found few papers trying to delineate this mechanism, and we have here what kind of neuroanatomical structures could be affected. For example, a disruption of frontal, parietal, limbic, cerebellar, interoceptive processing, and vestibular, motor, and proprioception that together with the temporal-parietal junction deactivation leads to the disintegration of neurosignature, and as a result, you have all the somatosensory manifestations and what they call out-of-body experience. And a better representation of this, once you have the appropriate situation, like the normal context, you're dark, alone, in a supine position, so you're asleep. There's a regional cortical activation or deactivation of parieto-temporal occipital cortex, hippocampus, dorsolateral frontal cortex, temporoparietal junction, and that leads to motor, somatosensory, and sensory effects. And as a result, illusory motor movements, out-of-body experience, and proprioceptive, vestibular, and different types of sensations. And it leads to activation of the amygdala and circulate gyrus, and with the sense presence, auditory, visual, tactile hallucinations. And once you're in REM sleep, you also have on top of it the peripheral motor paralysis that leads to breathing difficulty, sensation of pressure over the chest, and the death thoughts. I thought this was probably the most extensive representation of this phenomenon, and it tried to bring kind of the pieces of neuroanatomy to explain the two main phenomena, which one of them being the paralysis itself, and the other one being the somatosensory feelings, the hallucinatory events. And in terms of the limbic system activation, 72% of the patient from the paper from 2000 that reported fear, terror, panic, the authors postulated that this is most likely an amygdala stimulation, right? And singulates gyres for the emotional reaction, the threatening presence that was described in 1/3 of the patient, again, amygdala, the phantom noises, again, 1/3 of the patient, tinnitus with the reflex of protection against this impending danger, and it's a hypothesis that they brought on the table, and this oniric vision surround this, again, moving to the memory, hippocampus, amygdala. And if you recall at the beginning of the presentation, I mentioned that these patients actually have a good recall down the years about this event. And since we talked a little bit on, we touched on the neuroanatomy, my next question was, okay, what's at the level of the cell and the neurotransmitter? And I found 2 papers that I thought were representative. One of them is talking about the mechanisms implicated in the paralysis itself. And the other one, it refers to the hallucinations. So it seems like the mostly implicated neurotransmitters for the paralysis remain the GABA-B and GABA-A glycine receptors. And the REM paralysis, they found that REM paralysis was only reversed when motor neurons are cut off from both GABA-B, GABA-A, and glycine receptor mediated inhibition. And they also demonstrated that multiple receptor mechanisms trigger REM sleep paralysis. And here is a picture from that paper, and on the image A, it's shown how inhibiting just GABA-A, GABA-B does not produce the effect of paralysis, while inhibiting GABA-B, A, and glycine does produce the effect of sleep paralysis. Moving forward to neuropharmacology of the hallucinations associated with sleep paralysis. This is the one paper that I found, and I thought it was most representative, and it looks into serotonin 2A activation. And they also postulate on the new therapeutic drug. These authors mentioned that the hallucinations found in recurrent isolated sleep paralysis are serotonergic or pseudo hallucinations, and it's the same ones that happened with hallucinogenic drugs, and they tend to be dreamlike, with the experience having an insight or meta-awareness that is hallucinating. Unlike the dopaminergic or psychotic type of hallucinations, that where the insight of the hallucination is lost. And these authors spoke about the role of the 5-hydroxytryptamine 2C receptors vis-a-vis anxiety and panic during sleep paralysis, and the relationship with the orbitofrontal cortex, which is rich in these serotonin receptors, and that is influencing the visual pathways during the sleep paralysis and in effect the hallucinations. And they also spoke about a possible inverse agonist, pimavanserin, which is a medication that actually got approved as an antipsychotic for Parkinson's and Alzheimer's, but I didn't find any other data. It was just postulated in terms of like sleep paralysis. What's out there in terms of objective findings? So again, lots of research to find some PSG findings depicting recurrent isolated sleep paralysis. Most of the papers focus on the sleep architecture. So they look a lot about REM sleep, and I only found one recent paper from last year that actually looked into trying to record an episode per se of sleep paralysis. So this is from German authors, and these authors had three groups. One of them recurrent isolated sleep paralysis, controls, and narcolepsy patients. And they found that sleep latencies were prolonged in recurrent isolated sleep paralysis. There were no SOREMS episodes in these patients, and there were short, and that short REM sleep latencies, less than 50 minutes, were actually rare in these patients. The non-REM sleep stages distribution was normal, and there was no significant changes in the MSLT. There was no difference in the reported daytime sleepiness in their group of patients in terms of reported daytime sleepiness in sleep paralysis versus controls, but there was obviously more daytime sleepiness reported in the narcolepsy group. And also they looked into HLA typing, and they found that 7 out of 10 patients with recurrent isolated sleep paralysis were HLA-DR2 negative. And their findings concluded that the SOREM episodes are not a typical feature of recurrent isolated sleep paralysis. And in contrast to other studies, these patients actually do not have excessive daytime sleepiness compared to healthy controls. This is another study that looked at 19 participants from the same group from the Czech Republic. They found no difference in the macrostructural parameters of REM sleep in terms of percentage of REM sleep latency, REM sleep fragmentation also didn't show any significant difference compared to control. And their power spectral EEG analysis show a higher prefrontal beta activity in the recurrent isolated sleep paralysis group during REM sleep. So they concluded that there's an underlying persistent trait of higher cortical activity that may predispose patients with sleep paralysis to experience this recurrent episode. And this is the study that looked into an episode of sleep paralysis itself, and kind of trying to catch one of those episodes in the sleep lab. So they had 5 participants, and they were able to capture 5 episodes of sleep paralysis. And they found that there was a predominant theta EEG rhythm during sleep paralysis and false awakenings, with rare and lower alpha rhythm that actually suggests that the brain during sleep paralysis is not in a wake, but in a dreaming state. And from their paper, this is an episode of sleep paralysis in an 18-year-old male that lasts close to 30 seconds. And it's signaled by left-right ocular coding, which is something that they use so that the patient lets them know when it happens. And it's followed by the REM burst. And the second image that I found in the paper, this is in a 27-year-old female. So this is a 5-minute episode of sleep paralysis. And this patient also had what they called vocalization or moaning, like the patient was paralyzed, was trying to speak, but was unable to do so. So now that we went through literature and tried to see what is the pathophysiology, what are the underlying mechanism, and any objective data about recurrent isolated sleep paralysis, I embarked on another mission trying to find what are some therapeutic options. And there's, again, not much in the literature. Options are limited. There is not a single randomized controlled trial that has been conducted for recurrent isolated sleep paralysis. Most of the recommendations come from the studies of narcolepsy, either small case studies, either logical deduction from basic research. And even though different authors say that there are several promising psychopharmacological and psychotherapeutic approaches to treatment. Not much is out there, and one explanation for that could actually be the fact that this condition is benign, and more patients actually don't end up bringing it to their provider, and they don't specifically ask for a treatment, and they can live with the condition as it doesn't have any long-term complications. So that's why the most basic question that the clinician should consider is the treatment really warranted for these patients? And even in cases of significant distress, it has been described that very few individuals actually end up seeking out treatment due to several reasons. That could be, for example, due to embarrassment. So some medications that I found described in the literature, again, nothing is approved, and surprisingly, the most commonly used seem to be tricyclic antidepressants and SSRIs. And people believe, obviously, the mechanism of action would be the suppression of REM sleep. And I found some examples of tricyclics that could be used and SSRIs that could be used, but there's very mixed data. I actually consulted with Dr. Stroll and Dr. Gandotra, and Dr. Gandotra said we're not using SSRIs, actually have the opposite effect, it worsens sleep paralysis, but you could potentially use Prozac, and you can potentially use venlafaxine that have at higher doses, they have like a more noradrenergic effect. So they could be a potential target for therapy in a patient that desires that or has significant impairment. And again, well studied, but that coming from studies of narcolepsy, sodium oxybate, inconsistent studies, inconsistent results in different studies, and it is believed that may lead to reduction of sleep paralysis episodes, but no clear-cut conclusion on that one either. Psychotherapy remains the mainstay of treatment. And it's not necessarily CBTI itself, but a psychoeducation, reassurance, and normalization of the recurrent isolated sleep paralysis episodes. This could definitely have a positive clinical impact. Sleep hygiene measures are always a good thing to start with, and addressing insomnia as a separate, like treating it in case that's also associated with the sleep paralysis events. And in terms of CBTI, outside of the specific sleep hygiene measures, relaxation techniques have been used with good results. In vivo episode disruption techniques, ways to cope with a frightening hallucination, disputation of the catastrophic thoughts, imaginary rehearsal. This led to some improvement in the symptoms. And there's a recently published psychotherapeutic approach using meditation and relaxation paper. In terms of what research is being done, I didn't find much. The only one study that I found was the same that Dr. Gandotra had mentioned to me. And it kind of brings back the case study that I started my presentation with. And this is a phase 4 clinical study of FDA data about Suboxone and sleep paralysis. It's an ongoing study. It's mostly female people 30 to 39 years old, and it's a self-reported phenomenon. And they have so far reports of 2,397 people, but nothing much in terms of future research. And back to our patients. So If you recall, the patient that presented to our clinic earlier in the summer, he had a chaotic sleep-wake pattern due to his job with secondary insufficient sleep, and he was requiring long recovery sleep, which was the trigger for his sleep paralysis episodes. And he was experienced 3 to 4 per week. Probably some contribution to that of the trazodone, and he was using for depression and insomnia, with the trazodone being a REM suppressant and possible REM rebound. Also, the use of the opioid receptor drug that could alter the orexin levels. And if you recall, he had that history of substance use. Clinically, there was no evidence for narcolepsy, intracranial hypertension, PTSD. LFTs were normal for him. And his episodes were happening out of REM sleep. So, and no recurrent hypokalemia, no family history of the disorder either. So we concluded that he has recurrent isolated sleep paralysis with these contributing factors, including the medication. And the treatment that we recommended was reassurance, sleep hygiene, counseling, and close follow-up. So some take-home points to kind of summarize. So sleep paralysis could be either isolated, either in the context of narcolepsy. It's commonly associated with unpleasant sensations and feelings and fear and terror. Narcolepsy should be ruled out in the patients who have recurrent episodes. Patients should be reassured that this is a benign condition and it's not harmful, and it's not a mental disorder, assuming that that was ruled out. Most patients do not require treatment, and sleep hygiene is always the first to go point. Mixed data about the SSRIs, they can potentially be used in some cases, but no validated study on that. And CBTI seems to be a promising treatment at this point. Thank you.